therapy, which is activated before the ICD shocks. ATP is the device tends to override the VT. It increases its rate. It tends to suppress the VT. But if it's not able to do VT, then you get the shock. So in case the shock is also failed, inactivate your ATP. Increase the energy of your shock. As you increase the energy, it is more likely that it will change. Once we have done these two important things, if the shock was inappropriate, then what are the three things? This is our whole concept. SVT. Has it been given for instead of VT and SVT? Is it that the patient told that he had gone near let's say a fan, he was repairing a fan, he was repairing a battery. So avoid EMI, electromechanical interference. And third, these are the two external factors. And third are the pacemaker, the ICD itself is making mistakes because it is over counting its T wave as an R wave. If it's counting a T wave as an R wave, it will have two R waves. Instead, the rate will become double. So the left part is appropriate shock. The right part is our topic today. If the shocks are not appropriate, they can be due to SVT, they can be due to noise, or they can be due to double counting. How does the ICD work? First of all, it will see a template. If the rate is very, very high, it will analyze it as a VF. If the rate is in the zone of VT, then first thing for it to do is differentiate SVT and VT. So what it will do? It will, in a single chamber, it will see the rhythm. Is it becoming unstable? Common sense. Becoming unstable, likely to be AF. Was there a slow acceleration? Likely to be an SVT. Compare morphology of a far field channel from sinus rhythm. So what will it do? It will see its morphology which is achieved and a sinus rhythm morphology which you have kept in the device. Or the SVT morphology, it will compare. If it finds that the rhythm which it's getting in the far field is more than 70% matching the rhythm which is present in the ECG in your template, it will consider this to be SVT. So three important things. Rhythm. Is it an AF? It's irregular, it's an AF. Was it a gradual acceleration? Likely to be a sinus tachycardia. Is the morphology of the SVT which has been stored matching it? It's likely to be an SVT. So this is the example of a waveform morphology. This was the sinus rhythm which you have stored in your device, and this is the VT which you have stored in your device. So it will see whether it is matching 70% of its SVT morphology. If it's matching, it will say it's an SVT. I will not shock it. If it's irregular, AF. If there is a sudden onset, sinus tachycardia. If the morphology is not matching, if it's matching more than 70%, SVT. Three important things. These are not part of an ICD troubleshooting, but I'm trying to tell you this so that you can know what to troubleshoot. So SVT discriminator, how does it work? I told you it see the morphology. It will see the stability. It will see onset. Let's see the words. Can you see the words which you can display? Morphology, onset, stability. This is the basic of an SVT, of a ICD. And also important, it will keep seeing. But if the discriminated timeout is there, let's say it's not able to decide, it's taken more than 30 seconds, then it will say, okay, I don't care, let's give a therapy because it doesn't want the patient to collapse. So remember, SVT discrimination timeout is mostly 30 seconds. So very basic slide. Morphology, onset, stability. Three things it wants to match. So how does it differentiate? It gives an ATP response, I told you. It says, are the V equal to A? If the V's are equal to it, it can still be a VT, it can still be an AT. So it says if the AV dissociation is present and it's a narrow complex, it's a jet. So let's not go to jet, it's a different thing. What we want to support is arrhythmias terminated by ATP are likely to be VT because you're overriding it. You're able to ride a ventricular rhythm with the help of a ventricular beat. So important thing, if you see V more than A, likely to be a VT. If you see that the ATP was able to terminate it, likely to be a VT. So this is how a programming is done, because now we are going to start what we want to see. ATP1, ATP2, ATP3. It's going to try and override the rhythm. Burst and ramp means it will give 8 pulses of the same size. Ramp means on the next cycle of 8, it will increase its cycle length even more, so that the tachycardia, let's say tachycardia rate is 220. So they will try to do an ATP at around 230. In the next one, it will make it 240, because it has to override that cycle. Shocks, as you can see, you have shock number 1, 2, 3, you can change the value of the shock. So this is where your ICD troubleshooting starts. ATP 1, 2, 3, it will try ATP 3 times at different rates, and then it will give shocks. This you can also program. You can make it 25 joules. How will you program this? Thinking is, if you are doing it for a secondary prevention, that means the patient already had VTs, had collapse. Always make the first shock as effective as possible. And if it's for primary prevention, unlikely to cause, might try, then give it a little less shock in the beginning. And the subsequent shocks can be higher. Remember this thing? Monophasic shocks, biphasic shocks. Monophasic means in one direction, biphasic means both directions. And see, the direction is respect to the myocardium with the ICD. How are they different? Monophasic shock travels only in one direction, requires more energy, causes more trauma, more chance of burn, more myocardial damage. Opposite is all biphasic. This can be a theory question. That is why I put it, because monophasic and biphasic shock, because the devices itself are also programmed, so you should know. In a biphasic, the success rate is 90%, in a monophasic 60%. Essentially, all the devices which are coming new are now biphasic. So let's start with the shock therapy. This is the basic. The machine will first identify a VT. It has various ways. Its onset, its rate, its regularity, its matching. And so it's able to do all this. It's able to know whether it's an appropriate shock. So we go back to the algorithm where I told you if it's inappropriate. So the whole concept of troubleshooting is inappropriate. Appropriate means single shot, it was able to terminate it. Multiple shocks. Why? Because the ineffective initial shocks are because the initial shocks had lesser joules. It can be incessant VT has occurred, so many shocks are given. VT storm has occurred, many shocks are given. So now is our topic. After knowing the basics, inappropriate shock means it's an ICD put for life saving, but it's giving unnecessary shock. So it can be because of two reasons. One, it is tachycardia is there, but it's not a VT, it's an NSVT. So for an SVT, it has given a shock. Other thing, it can be absent. There is no tachycardia. What it has done, either it has taken the sensing from the EMIs, electromechanical interference, or it has done double counting itself. This is the whole concept of ICD troubleshooting. The ICD has mechanisms. The appropriate shocks are very good, it's life-saving. Inappropriate are the ones which you want to catch. Inappropriate tachycardia is there, but is it a true tachycardia? It's an SVT. It's only detected as VT wrongly by the machine. Other end, it is absent. There is no tachycardia. What machine is doing? From an EMI, it is sensing the electromechanical interference, the potentials, counting them and making it appear. Now we'll see example of each one of them. This is the whole topic. So why do these things occur? In an acute point, it occurs either there is a connection problem, there is a dislodgement. आपकी जो लीड लगाई थी आपने कनेक्टर में ठीक ही नहीं लगाई, as a result of connector misfire कर रहा है, या आपकी लीड ही हट गई. Now let's see how it will say. A person has been given a syncopal episode is there. You can see that the patient had a sustained VT with ejection of 25. Patient given an ICD. You can see the ventricular sensing is 12 millivolts. That means the R wave is 12 millivolts. And your capture is at 1.1. Very good. Patient doing well. Second day, implant again, in fact better. Threshold is 0.5. R wave is now more than 12. Patient wants to go home. But we are saying we'll give you some antibiotic and 10. Now 1 week post-implanting comes for an interrogation. He is doing fine. But there is shock in the absence of warning symptoms. He's sitting in front of you and suddenly you see a shock. He says, मुझे पता ही नहीं चल रहा. But you see that the R wave has become less than 1 and your catching threshold is more than 7.5. So there is some problem. So what can be the problem? This is the stored EGM. This is from a real patient of RGV Pant only. This was the stored EGM. Can you see? EGM means the device captures this report. See, it is seeing so many R waves. For it, it is all R waves. So it is sensing something wrong. So for it, it has achieved a rate which is even more than VF. So it is giving unnecessary shocks. So we'll try to find out what has happened. So this is what has happened. In the end, it has given a shock. It stabilizes for a second, again becomes the same thing. So this is what has happened. This was the first implant. His lead has actually penetrated, and that is the reason he is in trouble. So because now the lead is sensing everything when he is hanging in the air. So that means the lead is dislodged. So I have given this example because two important things. दोनों end के बारे में सोचो. Lead dislodge हो गई है, perforation हो गई है, connector आपने सही जोड़ा ही नहीं था. So dislodgement. Other thing can be the tip of the lead is perforated. So it's now in the pericardium. So every contraction which is occurring, it is perceiving it. So in that case, he'll have a chest pain, but this is the most common thing which can occur and give rise to failure of ICD. Now from there, I'll go to the other part. That means I'll just come back. I've explained this, lead perforation or dislodgement. I've shown you an example of perforation, dislodgement, it's in the air. Now let's go to connector problems.
Dr.
So
Kulia, sorry to interrupt. Maybe you can ask the questions to our dear students and ask them what do they understand? I mean, why it was giving too many shocks. So students, please write. So if you don't mind, Dr. Katuria.
So, but because I've marked all them.
So,
sir. In fact, it's very good. But I've given the answer on each slide. That's okay.
But I
so let's anybody and all of you, anybody can answer in the chat box so that sir can see. He'll keep communicating to me. What do you think is the reason this ICD is overfiring?
Write in the chat. What's the reason? He has explained everything. Unless you write, you will not remember it. You will not remember it. All this is a beautiful example. And now he has explained everything. So why ICD was firing, giving repeated shocks and considering that patient is having ventral fibrillation. Rate was very high. So rate based, it was very high. So sensing multiple signals as R wave at VF rate. Beautiful answer. So over sensing. Why it was over sensing? Beautiful answer. Everybody right. So that you remember it for the rest of your lives. So why it was over sensing? Sir has already explained. So sensing because there was lot of electrical activity. I mean, it was detecting the lead was Dr. Katuria, correct me please if I'm wrong. It was sensing. It was giving too many signals from myopotentials and everything. Is it true?
Yes. Because lead is hanging in the air. It has come out. So it is sensing everything which is happening around it. Every contraction it is considering, even the atrial contraction it is considering as ventricular contraction. So see, S, detection, R, SS, it is sensing everything. So for it has reached the rate of VF. So it will just give a shock. Because for an ICD, VT is discrimination, SVT is discrimination, I will think. But VF means do it right away. The capacitor will charge and give the shock. It has reached the rate of VF zone. So all discriminators are off now. Remember this line. Once the rate is in the VF zone, everything in the ICD is shut down. It's just shock. So the discriminators of rate, rhythm, SVT, morphology, all are off. For it, see F means it's saying fibrillation zone. ट्रिगर के नीचे देखिए आप सब इतना रेट हाई हो गया
Can you point out, Dr. Katuria sir, can you
Yes.
point out where that FF is written so
Yes,
that
see
our
this.
dear student can see it?
Can you see my arrow? Can you see my arrow?
Yes, we can see your arrow now.
So this is FFF. See F means now you are in the fibrillation zone. That means now the machine is shut. The first priority of this machine is save the patient.
Okay, so somebody is asking.
Even if it's an SVT, it will fire.
Beautifully answered, beautifully explained. So somebody is asking, what is capacitor? I mean, they want to know what is capacitor in one line, in a layman's language, kind of.
I have another presentation which has this, but I'll explain it. So capacitor means there is a charge. How does the energy is delivered? This biophysics shock is what? Energy, joules. It has to be created in the device. So device has a battery and a capacitor. Capacitor, as soon as all these things are detected by electrical activity, the capacitor starts charging. Capacitor is the one which has the capacity to deliver energy. So the capacitor is the one which says, oh, ये तो VF है. Okay, capacitor will start charging. If it is a VT zone, it will give time to the device. Please decision लीजिए, आप judge हैं, आप decision ले लीजिए. लेकिन अगर उसको VF दिख गया, it is like आपके सामने ही हत्या हो गई. वो कहेगा मुझे किसी की जरूरत नहीं, कोई मुझे जज नहीं, मुझे कोई लॉयर नहीं चाहिए डिफेंड करने के लिए. This is death in front of me. He'll say
to say, Dr. Katuria, many of them, our students do not speak English, do not speak Hindi. From various parts of the our great country.
ऐसा होगा. अच्छा, मतलब you want English or Hindi?
English, only English.
So what it will say is, or a judge, if he is able to see the crime occurring in front of him, he does not require lawyers to argue the case. It will straight away say, decided he has killed, hang till death. So for this machine, if the rate is above a particular range, everything else is shut down. It will straight away fire. This is what has happened. And very good. I'll tell you a lot of examples because Dr. Vimal has told me to stop on examples. By the end of this, you will exactly know how to interpret it. So now see, once it reached a particular level, the capacitor is charged. So after about few seconds only in this case, maybe 5-6 seconds, it has given a shock. Let's see what has happened. Shock has stabilized the machine. And again, within a matter of 1 second, it restarts because this is not a VT. The capacitor is firing in the air. It will never be able to do anything. Is everybody clear about it? I'll show you the example. See the lead. The lead is supposed to be in the myocardium. See my arrow. The lead is hanging in the RA. Can you see my arrow? Can you see the arrow?
Dear friends, say yes if you see it. I mean, sir is taking so much of pains in explaining. So whatever, kindly interact. So that we know that you are listening actually.
Okay. You keep posting it to Dr. Vimal. He'll be the bridge between you and me. Because if he speaks again, you will learn more. Because if he's just repeating what I'm repeating, it will keep happening. There's no need to cover a lot of topic. It's a very, very small topic. And you will encounter this throughout your life. If you don't know a good interpretation, you can put an ICD. But if your patient is suffering and he sees that you don't know it, he'll not rely on you for the next ICD. He'll never advise anybody to take an ICD from you. So this is very clear. So acute leg issues, you can have a perforation or a lead hanging. In this case, it is perforated. This was the video. So this is from our own institute where we had about 20 years back this picture. The lead had perforated into the pericardium. And with the pericardial movement, it was perceiving it as, every movement it was perceiving it as a heart movement. And because of the external noises, the patient had to be operated. Now, I'm again repeating. I was here. मैंने ये बताया लीड. अब हम चलते हैं यहाँ कनेक्टर. इधर की प्रॉब्लम्स बहुत सारी हैं. इसकी तो 2 ही हैं. Dislodge, perforation, मैंने दोनों एग्जांपल आपको दिखाए. I've shown you both the examples. Now let's come to what can happen here. Loose set screw means you had a little, you were little lax. You have put a lot of ICDs, you have rotated the screw, but the screw is not enough. It has not been able to screw it into the device. So what will happen now? Outside your arm, it will make a break noise. Means Sometimes when it is in contact, there's a good R wave, no contact, flimsy R wave. There is sensitivity in ICD. R wave pacemaker can be 5-6, but in an ICD, you should get very good R wave. So that micro signal can be eliminated by saying R wave means more than 4 volt. If your own R wave is 10, then only you can keep it. R wave only 4. How will you make internal voices will also be 4? You will not be able to discriminate. So most important, make break noise. See, make noise here. I told you there. Going everything fine. But it's breaking. Again going fine. Again breaking. Because there is intermittent contact of the lead with the ICD. So synchromity is working. When there is no contact, it doesn't know. Let me show you more examples. So this patient hospital has received 6 shocks in the last 1 hour. ICD implanted about 2 days back. He is in the hospital. So what is happening here? Can you see the break signals? See, I'll keep showing. If you want to comment, I'll keep showing you. And this is also a very big important slide to tell you something else also. See, here it is okay because the lead was in contact. Suddenly there is a break. So many signals have come. So as a result, see the annotation FS. That is sensing fibrillation. FS, fibrillation sensed. So it is giving shock because it is going into the zone of fibrillation. In the same slide, please see 2 things, EGM1, EGM2. EGM1 is tip to ring. This is known as near field. In your lead, there is a tip, which is the cathode, and there is a ring, which is anode. The distance between near field EGM. Near field, matlab lead, that means lead ke closest possible things dikhenge aap. And then there is EGM2, tip to reverse, tip to ring, or sometimes it is tip to can. The can, that means the broader picture. It will see the broader picture. It's like what I'm trying to show you is far field, near field. Above is the near field. 2 is the far field. Why this is required? You will come to know on your own as I show you examples. You will come to know on your own. So FS. So what has happened? This is EGM2. This is between the can and the lead. Can you see it is showing so many signals? It's all in the fibrillation. So why I'm trying to tell you this? If some problem is in the myocardium, the near field will show, the far field will not show anything. Usko pata hi nahi chalega. So if there is something in the near field, it is most likely always cardiac. So the response to near field is time machine. If there is something in the far field, because it's between the tip and the can is lying in your muscle, myopotentials, EMIs, diaphragmatic potentials. So far field will show problems, while near will show less problem. Here the machine has a very fascinating part. It will say the far field showing, but the near is not showing. Let me recheck if we are not. This is advancements of ICD. So because you have not put the lead well or your lead got crushed. Same thing will happen. So the problem can be sudden rise of your impedance, sudden change in behavior of ICD. So there is some sensing problem. Either you have not connected it well or your lead has broken. Now let's get to some examples. Can you all see this very well? I will like all of you to comment. I've already given the answer. Actually, I should have just kept it as a fly-in. Then you would have given the answer. But anyway, can you all see a lead noise? Yes or no? This can be due to anything. It can be because of a lead fracture. It can be because you have not put the lead inside well. But can you all appreciate it? Dr. Vimal, if you can ask the question.
Yes. Dr. Kathuria, if we can go at the, in the bottom, in the there are 2 images, A and B.
Yeah.
So whatever is written over here, AS, and can you explain for the sake of clarity?
Yeah. They're almost same, sir. They are of the same patient. There were 2 strips, so I cut it and put it like this. Anyway, let me explain it very easily. See the second step. Just keep seeing my arrow. There is a ventricular sensing. That means ventricle is saying, okay, there is a rhythm which is coming, but the rate is not that high. So let me start the discriminators. But again it says it is irregular. See VS, just keep seeing VS. Ventricular is sensing something. It is saying it is coming irregular. So it is saying, okay, it might be AF because it is irregular. Okay, it keeps seeing, it's trying to discriminate, but see, it has not fired. So the noise is there, but the noise is not able to generate the value of VF. It is generating the value of VT. So in the VT, the discriminators are working. One is saying, this looks to be the regular, it is AF. One is saying it is not matching the SVT protocol. It can be VT, but it's in the VT zone. But suddenly now see the part. Can you see my arrow? F has gone to fibrillation sensing because now the noise has increased tremendously. Am I clear?
So Dr. Katuria, to make it clear and for me and for everybody, so earlier the rate was not that high. For VF zone, something like about 200 or something may be required. So rate was lesser than that, whatever you have set over there. So is it like that? So it is, unless your rate is absolutely
yes. So
high,
till the rate, yes, that's what I'm trying to say. Yes, that's the crux. Once the rate goes beyond a particular level, see, such a good example. This is such a good example of the machine being so good. Till the time when it was VS, ventricular sensing, it was using its discriminators. What are the discriminators? Rate. What is the rate achieved? Rate is less than VF. It will say, okay, I'll start it. Is it regular? Is it a sudden onset? Is it matching the morphology? It is doing everything, but not giving a shock. As soon as the rate goes into FS zone, fibrillation zone, it closes everything. It says now shock to be given. So lead noise can be in the VT zone, in the VF zone. Let me show you more examples. I'll tell you how to differentiate even an EMI from a lead fracture.
So
lead noise.
Clear. Everybody's
this
clear.
Now this lead will make very clear.
Yes. Go ahead, sir.
Now please, Dr. Vimal, ask them what do they feel. I've written the answer. I've written the answer, but ask them what do they feel.
So see, we need a little bit more clarity on the near versus far field. We'll come to that. Before that, is it?
There's no need to complete. It's important that you understand EGM. There's no need to complete the This slide which I've reached, you want to understand. I see this difference. Explain it once again because examples of these only in the near field there's a noise. Correct? Can you
point out? Can you use the noise? How detect it once again?
But in the far field there is nothing. The far field is regular. The near field this kind of small swing. So the device is now seeing in the near field is something, but far field is nothing. But near field is more important. I told you it is more important. So it has started sensing. And you see, it has started saying FS. So it is reaching fibrillation area. So how come the lead noise is doing it? So when the lead is fractured near, if it is most common area of fracture is near the subclavian, but by chance this lead has fractured near the ring. So the far field is empty, but the near field is showing noise. But see, important, if the R wave is very good, so you have kept the sensitivity of R wave as 8, all these small will not be detected. But probably the implanter in this case had a small R wave, so his R wave itself was 4, so it was sensing the small t also. So this slide is absolute brilliant explanation. Near field is bad, far is good. It has to be VT. But again, why is it's not reaching the zone? Because in this patient, R wave was kept low, so it has come into the fibrillation zone. So the near field is more important. So in this case, for a lead noise also, it will give a shock. Let's go to a true ventricular fibrillation. In a true ventricular fibrillation, the near and far both are showing fibrillation. It has to give a shock. So this example shows even if the near is misguiding you, your R wave in all ICD should be very good. Once you start putting an ICD, R wave not finding good in a pacemaker is okay. But if you don't get a good R wave in ICD, means you're in for trouble as soon as you go in practice.
So
again, see,
beautifully explained.
Yes, sir.
Beautifully.
Yes, sir.
So can anyone answer what is meant by good R wave at the time of implant? Good voltage for the R wave
Yes,
implant.
yes.
Can anyone explain? I mean, even if they explain it little, wrongly or written off track, it is okay.
It's okay. So explain it in the context of case number 1. Keep seeing what I have written there. This is an actual patient of CVP. So see what we have written there. At implant, V sensing is 11.4 volt. Can you all see? And now, second day, it is even better. Even better. But on the third day, on the 7th day, just see what has happened. This is what sir is asking you.
Yes.
Now in the context of
yes, somebody
Please
written
explain what sir is asking
amplitude of at least 5 millivolt. So bigger the R wave, I mean,
Yes.
chances of machine acting on something like small myopotentials will be unlikely. But it will be dependent
Absolutely.
on a very good, implant technique and implant there. Because if you are getting voltage of something like 8 or 9, then small voltages will not affect the machine functioning. If you are not able to get it, let's say you keep
Yes,
it at 5 or
yes,
so as
yes.
stated, then you are in for a lot of trouble as stated very nicely.
Okay. Now let's get to the next step. All of you answer to Dr. Vimal itself. Lead fracture, connection problem. But see, tip to ring, near field, can to coil, far field. Please remember this in your life. Can to coil in this case is, if you see the lead fracture, it is fractured near the tip. That is why the near field is showing a problem, but the far is showing much less problem. If there is a connection problem, and the connection, because it stays from up to down, connection is throughout, your problem at the tip to ring will be much more profound. Oh, it will have problem at the coil can level also. Let me take to another example. Now this is complete lead failure. Can you all see what is happening? The lead in between has broken. Because the lead has broken, the firing of the lead itself is manifesting, whether it's a far field or a near field. It is a lead field. Now this was all about mechanical problem. Loose set screw. There is in fact a case published of air bubble left in the connection screw and fracture of the lead. Now these are all mechanical. What can be the other non-mechanical sensing problems? Remember EMI, patient was absolutely okay. But while doing his job, his son called him that this fan is not working. So he climbs on a what do you call a stool and tends to correct the motor of the fan. So what is happening? The fan electricity is sensed by the electric current is sensed by the device. Remember EMI will be in all sensing channels because for EMI it is coming from above and reaching the device at all levels. So whether you are tip to ring, whether you are ventricular tip or you are at CAN, you will have an ICD showing FS, fibrillation zone. It will keep firing. So I wanted to go back to this slide once again. And yes. So we have already done the part of intracardiac problems. We are now coming to EMIs and myopotentials. So this was device mechanical problems, EMI. Now, second, myopotentials. Myopotential means These are generated from something like a muscle twitch. If somebody has a neurological problem, he has twitches. So the twitch will reach the far field first because twitch is near to what? Twitch is near to the device. Can you all see so well? Coil to can. It is showing fibrillation zone. Coil to can. Why I have made it red? Always remember, physiological problems are high frequency, low amplitude. High frequency, all the lead problems, means lead fracture, are ulta. High amplitude, low frequency. I'll show you in the end. So this is a typical example of a myopotential coming from a muscle which was near to the can. So it is showing fibrillation zone. Skeletal muscle oversensing. So rib muscles, intercostal muscles, they are showing some activity. So from the muscle it got conducted, reached the can. Once again, see, everything is in the far field. It is upper extremity muscles, abdominal muscles. Isometric exercise by the person, again the muscle becomes taut, not in isotonic. So this is an example I've taken from AIMS. Diaphragmatic myopotentials. Same thing. All of them will be high frequency, low amplitude. Now, see the difference. All other muscle potentials are in the far field, while diaphragm is near the heart. This is in the near field. Please try to understand. Diaphragm is resting below the heart, so this lead near potential will carry. Now, to make it simple for you, this is the explanation. Simple. Lead fracture. See the problem. It is high amplitude but low frequency. Low amplitude, high frequency means potentials. It can be EMI, electric interference from the, muscle, diaphragm, skeletal muscle, pass ki muscle, anything. Remember, you should have a picture. If you see such thing, itni tez ho raha hai. High frequency is always physiological. Low frequency but high amplitude is always mechanical. Now, we have done the fracture part completely and the potentials part completely. So we have covered this part of our problem. Okay, extracardiac, something was coming from potential, some myopotential EMI. All this is no tachycardia, inappropriate shock because of this. Now let's see what the device can make mistake when there are no potentials, but the device makes mistake. Why will it make a mistake? Let's see. So, what has happened now? Because your R wave was low. Again, R wave double counting has happened because your R wave was low. Because you had only R wave 4.5 and the T wave of the person was 3. So you had a very narrow window. So because to make sure you don't want to waste the VF, you have to make 3 because you want to do everything above this VF. So the T wave is counting. This is a typical exam picture which will give us a spotter. Railroad track pattern. Railroad track is because R wave is bigger. The upper is R wave. The lower in between. देखो दो R के बीच में एक T है. In between two R will be a T. So it will be little lower, but it will keep coming in. This is known as railroad track. This will become a railroad ka track. Upper R's, below are T, but the T's are perceived as R. So it is now double counting the T wave. Okay. And what will happen? Number is more, it will fair. It is tachycardia. So the characteristic railroad pattern of stored intervals, which you will have as a MC, as a Viva question, as a spotter, is that your R wave was not good. How to resolve it? Now this is the counter slide for any slide of ICD troubleshooting. What you need to do? You need to increase the V sense. You will have to tell the machine, "Arey bhai, 3 millivolt is T wave. R wave is more than 5." If you want to count it as VF, because original R wave is 13. So VF will take as 5. See, so below 5, please don't count it. So this is the important thing, R wave counting. So if you want to resolve the R wave over counting, just increase the value of R. Now say 6 is the one which is the value. So you can only do it if you have a good RV. So you see increase the sensitivity of the RV. Now you'll ask, it is a very difficult task. Let's say somebody is ICMP, 5 साल बाद और muscle has become even thinner. So the R wave which you kept at 10, now you interrogate R wave 5, but everything is in place. So that is why now all ICDs in the world have auto sensitivity testing. They keep testing it after every 380 beats, 400 beats, it rechecks. But is the sensitivity same? It says no, the R wave has decreased. Let's say after 2 years. Okay, then it will increase its sensitivity on its own. That's known as the tracking principle of new VTs. So whatever I've taught you now, the machine does maximum on its own. So this is just to show you the same thing. See, there is a R wave. Can you see the R's are R's? And can you see the T being perceived as R? So that is why now both of them are R. So this is fibrillation zone. Is it clear to you? Now this I want you all to answer. Please answer. Hello?
Yeah, yes. So can you ask the question again?
Am I audible?
Yes, you are audible.
Yeah. So
what do you want them to answer? Let them answer only then. You do not, prompt them kind of so that we know.
I've already written. Now this slide has everything. I've already written ventricular oversensing. Ventricular oversensing.
So tell us.
So I want them to answer.
Yeah. Tell us, friends, where do you feel, what do you see in this ECG or EGM, intracardiac electrogram? So can anybody answer? Yes. Can anybody try? Try something.
Answer the question. At the same time, please see this to ring. Can to high voltage ring. Both near field and far field. Remember, every company can change its far field. Some keep ring to CAN. Some keep ring to the SVC coil. This can change. This depends upon the machine, the company. I have made a box also. Now please read the box. What it is oversensing? What is it oversensing? Vimal sir, am I audible?
Yeah, 100% audible. So somebody is writing R wave, T wave as R wave. That is
very good. Very good. Very good. Now, all of you keep seeing my arrow. My arrow is visible now? My arrow is visible?
Yes, it is visible.
So keep seeing my arrow. What has happened? See.
So for the sake of clarity, because it appears people are a little bit, they need more training kind of. So we will, on the right side where your arrow was, we will go one by one to all the tracings actually.
Yes.
What is happening?
Yes.
For example,
so let me go one by one and explain you.
CAN to ring.
See. Yeah. First I'll explain, then we'll get back to them with some old examples so that instead of going more, I just want them to learn this much.
Yes,
this is ICD troubleshooting.
That's good enough.
EMI, lead noise. There is nothing else. There is nothing else. So, see, can you see the amplitude of the R wave? And can you see the amplitude of the T? They are almost equal. That is why this is oversensing the T wave. And see now the below. First it was sensing VS, ventricular sense. Now it is confused. This is also lost like a ventricle. This is rail track. So now all of them are for it becoming almost equal. So it is going to reach to the level of rail track VF soon. So the sensitivity
so now for each heartbeat, it is counting as 2.
Yes, sir. Yes, sir.
So it is, students, it is, dear friends, say yes or no, say something. Okay, so it is counting as one. It is counting as R wave, as nicely explained. One beat as per the detection is R wave. The second beat is T wave. So for each beat, so if, let's say rate is 120. So now it will be detecting as 240, approximately. I mean, some may be missed, but approximately it will be like that.
So I'll tell you what Dr. Vimal sir is saying. Now go to my arrow once again. Just keep seeing my arrow. Till here it is tolerating. Ventricular sense, ventricular sense. As soon as it becomes equal, it has changed into FS, vesicular fibrillation sensed. Because the basic rule of ICD is save the patient. Even if it wants to give a false shock, it wants to give a shock because it doesn't want to meet even a single true shock, because that will kill the patient. This is what should be in your brain. ICD does not want to mean even a single true shock, so it keeps giving false shock. But as the discriminators are becoming better, yes, sir. So as the discriminators are becoming better,
yes. So I just want to talk
now
to them.
serious.
I mean, yes. So if the rate is particularly high, then it will continue to give the shock. Rest all the criteria, whether the
Yes,
QRS or morphology and whatever,
Yes.
they will all
It
be
doesn't matter.
overruled. It has
It
been
doesn't
explained
matter.
again and again.
Yes,
Because VF means that patient is dead.
Yes, sir. Yes, sir. So let me get back to them. You please keep telling all. Everything closed. Everything closed. If EGM says rate more than 220, machine will say, go to hell, I don't want to see anything. It is VF. But if VT, zone VT, it will analyze EGM to differentiate SVT and VT. It wants to give a chance to the heart. Why to give a shock? 3 discriminators. Go back. I want to see this. 3 discriminators. Morphology. There is a morphology template which is stored in the machine. This is the morphology template of the machine. It will match. As soon as it says more than 70% match SVT, it will close itself to morphology. Second, sudden onset. If it says it just suddenly started, it is suddenly terminating. If it's something like a sudden onset, it will say it might be sinus tachycardia. If the sudden onset is there, which is causing any kind of fluctuations, it will say fluctuations don't occur in stable tachycardia, it is AF. Remember these 3 things of the device: morphology, onset, interval, stability. 3 things on which the device works. Only when there is a VT zone. VF zone means problem solved, nothing to be done. VT zones means I will treat these things. VT zones ka, I've again told you, unstable rhythm, AF, gradual acceleration, sinus tachycardia, sudden acceleration, there is some SVT. I will differentiate it from VT. Remember these 3 lines: unstable AF, gradual sinus, sudden onset, some type of SVT or VT. I will use morphology to differentiate them. I will use gradual acceleration to use, if it's a gradual one, I will use this discriminator of sudden onset or not. If there is some instability, we will use interval. These are all pre-programmed in the device. Now the important and fortunate, unfortunate thing is, when I started ICDs in 2008, all this has to be programmed. You keep changing them in all of them are becoming dynamic programmers in ICD. As soon as it says, Pishli bal, I made a mistake. It was not a sudden, it was a gradual onset. But the gradual onset was also VT. Next time it will reprogram the gradual onset window. Gradual onset window reaches a heart rate of 220 seconds. This time it will change it. Machine will itself auto. 210 seconds, 20 seconds wala is also VT. It will change the value. So what you used to do as VT as programmers, most of the time machine is doing. But remember, interval stability, morphology, sudden onset, offset, all in VT. VF, everything closed. Once again. So remember, once it gives a shock, then again it has to analyze. It is not necessary shock will morphology of the beats that immediately follow shock. be relied. So the machine gets a rate, will go back into giving shocks. But beats that follow ATP, which I've not explained here, ATP. ATP means I told you is increasing the value to override it. The ATP values which are there, that beats can be followed because ATP doesn't get into or change the morphology.
Can anyone tell what is ATP? What is ATP?
Yes.
Students,
Full form of ATP.
Full form of ATP and one line about ATP.
At the same time, while doing this, can I share another presentation in which the ICD it is there.
Yeah, you can show. We have 10 minutes or so remaining. We can continue in the next class also with more examples. But so what do you mean by anti-tachycardia pacing? Very nicely said, ATP full form. What is there? See, any machine has a limited number of shocks. Besides causing a little cardiac damage, besides causing huge inconvenience, anybody has ICD, he has a shock, it means he has a near-death experience. Not a good thing. Unnecessary shock, therefore, are bad. Secondly, if you machines have something like about 250 to 300 shocks they can give, depending on what is the juice you have kept. So after that it will be waste. I mean, the whole battery will get depleted. So shocks are from that angle also important, that you do not give unnecessary shocks because battery. So anti-tachycardia pacing is the one. So can anyone tell a line about anti-tachycardia pacing?
Is my slides visible? Is my slide visible?
Yes. Make it in PPT form, presentation form.
Yeah. So ATP, anti-tachycardia pacing. And this is how it works. Very simple. If somebody is running, how can you beat him? Just run faster than him. You will beat him. This is what anti-tachycardia. Tachycardia is at a rate. The basic premise is it wants to break that loop, so it will run faster than him and enter his loop. It will run faster than him and enter his home before he reaches. So it will disrupt. Simple. Run faster than the tachycardia.
See,
that is anti-tachycardia.
Beautifully explained. So, see, one of the basic principle of cardiology is that heart runs on one simple principle. Every tissue of the heart, every cell of the heart can produce, in the myocardium, whether atrium or where, can activate the other this thing. Can generate. But they are faster to be captured by others. So if you pace it faster, you override it, and after that you simply break it and it will get broken. If not, then we have then shock will be delivered.
Believe me, in 2040, 50, there will be no shocks in ICD. ICDs are now working even the VF zone of ATP. I can post to sir, and sir will post it to all of you if possible. So what are the ATP effects? Termination. But what can be the side effect? You are try to run faster, and that person sees you and he says, I can run even faster than him. So the tachycardia comes to your aid. So there will be acceleration with the same morphology. You are running against a person whom you want to override. You have run faster than him. He sees you. He says, I will catch you. He catches you. So the VT will become faster. It might become fast. It might just change the lane and take a shortcut and try to become faster than you. So acceleration with a different morphology. Third thing, it might collide with you. It says he cannot go beyond me. I'll catch him. So what it will do? It will take his hand and try to pull you back. Now both of you will fall. So they can degenerate into ventricular flutter fibrillation. Remember, the good effects are the one which I've told you. I've told you the good effects are what I've told you. The bad effects are it can become as fast as you are. It can change the morphology, change its shape, become fast, collide with you and generate into VF and kill the patient. These are the three different effects. I've explained you in a simple way. So, this is what I wanted to explain you. There are pulses which can be burst. There can be other forms of ramp And I can explain you what is burst ramp. Simple. Burst means keep giving at the same rate. Always remember, it gives 8 impulses weights. 8 is the word. ATP scheme is 8. So let's say it gave at 280. The tachycardia cycle length is 260. 280. Tachycardia is still going on. Burst will remain same, but in a ramp, the next will become at 260. On its own, machine will change it. So burst and ramp are examples of these. And furthermore, if you want to see, there is also one scan in which every beat it changes. Every beat, it will change in every beat. That means burst is same occurring every time. Ramp is next one becoming bigger. And scan is everyone becoming bigger every time. So, but what has happened now? In all the machines, it is ramp and scan. Burst has been eliminated. The now in the new machines, this is a very old slide, somewhere around 2016. Now is no burst. This is ramp scan. That means every beat they're changing. Only purpose, catch the tachycardia, enter its house, close the door, it will not be able to make it. So that means ATP will always work in re-entry circuits, where it has to move in re-entry. Automatic circuits, triggered activities, no role of ATP. That is why ATP works in ischemic VTs, because ischemic VTs are re-entry VTs. Other VTs it doesn't work. I'm just giving you examples so that you learn the subject per se. So these are example of burst pacing, ramp pacing, scan pacing, but now ramp scan is the word. This is being followed now. Every beat decreased. So, sir, if you want, I can explain ATP also in various form, but
I think we will close it here. I mean, after
yes, sir. But I think the basics have been very clear.
Yeah.
We have been very clear about the shocks. One last word I want to say. Remember, till 10 joules, the feeling of the patient is same. 10 joules ka shock is same as 5 joules. It's little different. I'm sorry. Till 10 joules, it will be different. If 5 is less pain, 10 is more pain, 15 is even more pain. After 15 till 40, the pain is same. Remember this. If you are doing a secondary prophylaxis, patient had a VT, don't go for low zones. Only because the patient says, I get very disturbed. Let him get disturbed. Not important. Remember, till 15 joules, there is aggravation of pain. From 15 to 40 joules, the maximum joules available in today's ICDs is 40. It's all same pain. If you are doing for primary, you can keep 10. Chalo usko pain ka ho, then you can make it 40. But if you're doing for secondary, make it 40 because 15 will be ineffective and will cause him the same pain. So let the first one take care of it. The first should be 40 joules.
So are you clear? However, having beautifully explained, but if higher shocks drain more battery compared to lower shocks. So
yes, of course, yes.
So a machine will be able to give. That's why he's saying time duration lower. So if a machine can give, if you give, let's say, 15 joule shocks, about 300 or so, or it will depend on so many other factors. For example, routine day-to-day activity will also drain the life. So shock-wise, if you take a machine now and tell it to keep delivering new machine, so it will deliver maybe 250 or so, 250 to 300 shocks of 20. So if you make it 40, now it will delivering maybe 150 or 175 shocks. So all these things have to be considered. Plus, it will be routine activity also. So battery life and machine longevity have to be kept. Everything. So it's a question of checks and balances. Very nicely explained. So
sir, last thing.
Yes,
Somebody was capacitors. Now this is a slide of capacitors. Capacitors are first charged and then discharged through the lead system. Capacitors are first charged. That means when the machine is making a discrimination between VT and SPT, the capacitor will start charging. And then resulting waveform, whatever is the answer, it will deliver energy. Remember, delivered energy is always less than the stored energy. Why? Because when the capacitor is charging, it is still using its power. Because it is saying, let's say it converts into VF, the charger will straight away fire. So remember, delivered energy is always less than the stored energy. The capacitor is the one which takes time to, in the VT window, to do something, not to give a shock. Capacitors are the real life of ICD. That is why somebody has a lot of ATPs, its capacitor is draining because it will be charging while it is giving ATP. Because it will say if the ATP fails, the patient will die. It will keep charging. So ATP will prevent only pain to the patient. But the capacitors will still use
Beautifully explained. So if the capacitors charge, beautiful $1 billion statement. Once the capacitor charges, it has already discharged. Let's say it does not require to give a shock, then it will slowly dissipate the energy. However, that battery is already exhausted for that shock. Once your one shock, let's say your so your 1 rupee is already gone.
or not.
Yes. So everything has to be. So you have to keep. And batteries, these do not come with lifetime warranties. They limited.
Yeah, you have to pay again. You have to pay again.
Yes, you have to pay again, kind of after certain. So somebody is saying if the and lastly, all devices, if you have the ICD, does not mean that sudden cardiac death will be prevented. It will prevent it maybe 90% time, 10% patient will still die of shock. Absolutely. If you can't talk of all shock deaths. So that answers the question. If patient has BP, when ICD will give shock, yes, if ATP try ATP, clear it will give shock, then likely it will fail.
Quickly answer. This is the clinical efficacy answer of what Dr. Gurusar was saying. Even in VF, there are 1.5% people who will die in spite of having a ICD. See, VF is converted successfully 98.8%. 1% even VF will die despite the battery using everything. Because that's too fragile and hard.
So it depends on so many factors. Let us say patient is having he has a recent fresh MI. So he has continued to develop. So it's a combination of factors many a time. So in general, so when you implant, you do not tell the patient that we have given you immortality. So there are various scenarios. I mean, you can have a whole class or a whole discussion on it, where despite ICD functioning fine, beautifully, so ultimately the outcome may not be favorable. But if you understand it well, you program it well. Once whenever shock is there, patient will come back to you 100%. He will say, "I had a shock yesterday." He will not say, "I had a shock 1 year back." He will come back next day, maybe same day, and tell you, "Check what is the problem. Am I dying or whatever?" So then, and at that point, you don't know all these things. Then you are